Hello, sir.
Yes, please.
Regarding irrigation, what is the concentration steroid
Yeah,
irrigation you are
yeah. We will discuss in the post-operative. I have made a separate presentation for the post-operative part, you know, to tell you details of all those. Want to show something regarding the frontal sinus. Hello, hello,
Hello.
hello.
Yes, sir.
Yeah, this is to discuss certain things about the most difficult situations of the frontal sinus. What you have seen in a revision frontal sinus is the simplest procedure you can think of. The simple draft to be on the same side. We have discussed modifications of the draft, so many modifications, modified subtotal, modified Lothrop, modified mini Lothrop, hemi Lothrop, central Lothrop. So once you have a persistent sinus disease, these are the options. In order, either do a revision procedure like what you have done earlier and revise it thoroughly, or do a draft procedure, modified endolymphatic Lothrops. Open counterpart for that is osteoplastic flap if you are not able to do endoscopic procedure, or if Lothrops is not indicated, then osteoplastic flap. Osteoplastic flap means you have to come from outside with a bicoronal incision, remove the anterior wall of the frontal sinus, remove all mucosa, drill everything, remove all mucosa, block the frontal recess, and obliterate the frontal sinus with fat or something. That is osteoplastic flap and obliteration. That is required when your drainage procedures fail. Even your modified endoscopic Lothrops fails, or when the modified Lothrops is not indicated. So when it is indicated, see in modified Lothrops or draft like you saw, you need to have a big frontal sinus to give wide drainage, otherwise it may stenose to some extent. In cases where you don't have a big frontal sinus, what you can do, you can, that will be easier for the obliteration and permanent answer. Osteoplastic flap should be considered in revision procedures when you don't have a big frontal sinus, when you can easily Demucosalize it, remove all the mucosa and obliterate it forever. If you try to do that in large frontal sinuses with a lot of convolutions, convexity, and scallopings, it is very, very difficult to remove the mucosa in entirety, and then obliteration is not indicated. In such large frontal sinuses, if you take up obliteration, you may not be able to clear the mucosa thoroughly, and if you try to obliterate, you can it can lead to mucocele further if the mucosa is left behind. So that is easier in sinuses which are smaller. So in those difficult sinuses, revision surgery is done, fails, revision again and again. You can take up osteoplastic flap if the sinus is small, if the sinuses are small. Even if your osteoplastic flap is done somewhere and still giving problem, mucosal and all that, if the sinuses are big, you can do a revision draft 3. So both the things are possible according to the need. So by and large, for the smaller sinuses, obliteration. In revision situations, even the draft fails. Primary is draft for everything. If smaller fails, osteoplastic fail. Otherwise, you can revise the draft 3, or in the most difficult situation, like I am taking up the next case, there are 2 procedures which are, eliminating procedures. Eliminating means you have to eliminate the frontal sinus to give problems in future. There is no frontal sinus in future, no problem. Kind of cranialization means the posterior table of the frontal sinus separates from the cranial cavity. If you have disease where the posterior table is deficient because of the disease, you can remove the entire posterior table, demucosalize the sinus completely, obliterate the frontal drainage pathway below, and allow the dura and the cranial cavity to expand until the anterior wall. So the frontal sinus will be eliminated completely. There is no question of problem in the future. So that is required when your multiple procedure fails and the posterior wall is deficient. That is cranialization. The frontal sinus becomes a part of the cranial cavity. You remove the posterior wall and allow it to expand to the anterior wall. That is cranialization. Converse to that, if your anterior wall is deficient, gone, and frontal sinus is difficult to do, in spite of all procedures, still giving problems, remove the entire anterior wall, drill away all the mucosa until you get the normal bone so that you can remove the mucosa and all, osteitis and all bone, and allow the facial skin to fall on the posterior wall. That is facialization. You have to block the frontal outflow. And in order to prevent deformity, outside deformity, you can use bone cement or something to line for the camouflage, and the skin can come over it. That is facialization. This was described by Riddle, long back. Riddle's procedure, it is commonly known as. So, according to the most difficult situations of the frontal sinus, you may have to take a call of cranialization or facialization to finally eliminate the frontal sinus to give any problem in future. So these are all the procedures. One or a front endoscopic surgeon must be, keeping in the armamentarium such procedures which can be of use, and we have done a couple of such earlier in our practice because they require such kind of approach. Now coming to the next case. See this. This is a little complex, more complex than what we have seen earlier. See this lady who has undergone sinus surgery earlier. This particular patient, I'll show in all planes what a complex situation. This patient has undergone sinus surgery. See, the rest of the sinuses are all good. Can you see? Hello? Is it visible? Are you getting the scans?
Yes, sir. Visible, sir.
See
Yes,
now
sir.
when I am going anteriorly, what is happening? See posteriorly all good. Now coming anteriorly, see the same story. See the cells in the frontal recess, can you?
Yes, sir.
Yes, sir.
And now as you come up, see, because of the pressure or erosions of the frontal sinus walls all around, erosion looks like osteitis also with neosteogenesis because of the ongoing persistent inflammation. See how the frontal sinus walls have become neosteogenesis. See this?
Yes, sir.
Erosions of the wall. And this is the picture of the frontal sinus of this particular patient, which is giving her highest level of trouble. And this is the case should be dealt with very, very effectively by a more extensive approach, since it is bilaterally involving both the frontal sinuses with most complex issues of neosteogenesis, obliteration of the outflow, erosion of the surrounding walls. And see, I show in all planes. This is one of the most complex situations one can think of. See this? If you see the frontal sinus one by one in the sagittal, see if I change the window setting. See, this is the bone which is gone, and see the inflammation in the frontal sinus. See the osteitis, neosteogenesis. All this is going on without intracranial involvement. This bone is gone. Opposite side also the bone is gone. See, at times the anterior wall is also eroded. At places the anterior wall is also eroded. So all around it is massive destruction of the walls because of the ongoing persistent frontal sinus disease, which is not cured by the previous treatment because of the what I believe is the inadequate work, inadequate widening, inadequate cells removal in the frontal recess, and the complexity of the disease, the inflammatory profile, and all that contributed to this. Now, what can you do for this patient? Anybody?
Lothrop.
Revision, same sinus surgery, same revision sinus surgery. Can that help? Big
No,
no, big no, because this has given such a huge osteitis, neosteogenesis. This requires a thorough irrigation post-operatively, which is not possible through the narrow opening now. If we try to revise, it is bound to fail. So now it requires a bigger procedure, complete marsupialization. The first try should be modified endoscopic Lothrops to regain the drainage again. The issue is to gain the drainage and delivery of the medications, the topical steroids, further by removing the floor of both the frontal sinus. We'll remove the floor of both the frontal sinus completely so that our topicals will reach effectively inside everywhere in the frontal sinus. So that is our first procedure. Let's see what it turns out to be. Don't frighten with these bone erosions that can happen because of the ongoing disease. The bone erosion and neostenosis both are part of the inflammatory process, and that can happen. Let's see how the drainage gives the avenue for the topical access, and that should give her a big relief, and the pathology can subside. If we find something beyond, a lot of posterior wall is eroded, you have seen in this case, and if it demands further any kind of the treatment, we can think of elimination procedures later on. So I have kept an option of elimination procedure for this particular patient in case required for future, because this disease is so massive, and we have to do something definitive. The first attempt in any given situation, such cases where the frontal sinus is not so small, it fulfills the criteria of a draft 3. See, the frontal sinus is big enough for the draft 3 to be contemplated, and a drainage process is re-established. So there's a good case for the draft 3. Headache. Serious headache, and that is a massive presentation. See, I told you, primary sinus surgery, untreated sinus surgery rarely gives headache in spite of the complete whiteout. Yeah. Fine. But a revision, once you give this kind of a picture, is block because of the previous surgery, iatrogenic blockage, iatrogenic drainage blockage, they become symptomatic. Some
Sir,
sort
do
of.
we,
Hello?
sir, any CSF leak to be
No,
expected?
not at all. This is not herniation of the brain as well. No herniation of the brain. For that matter, you see the window setting change. See the bony wall is thinned out, very thinned out, but it is there. There is nothing herniation from above. We change the window setting, you get a lot of things. You can additionally get MRI if you have a doubt. See, you can see the thin bone. Still, you can see the separation of the cranial cavity from here. The
Yes.
issue is, see the anterior wall, big anterior wall erosion, posterior wall erosion. Everywhere, there's a massive situation. And now it requires a definitive work. This has developed even a small periosteal sort of, inflammation outside with a bulge because of this ongoing inflammation that the anterior wall eroded. I will show with the endoscope. Lamina pepraceae. Another question from here by Dr. Islam from Egypt. See this. See, by the previous surgery, this lamina pepraceae anteriorly is gone. See this? You have to be careful. But see, our draft drilling is above the level of the orbit. So don't worry. See, the orbits are here. Orbits are here and drilling for the frontal sinus is all above. But you have to keep in mind. Charger लगाओ इस. Where's the charger? चल नहीं रहा है. दूसरी जगह लगा इसमें. Yes. So this is the picture of this patient. It's a massive disease. And this could be something else. If it is, you have a doubt, must get the MRI done. Though we don't have a MRI for this patient. Since it is a previously, sinus surgery patient with purulent infection coming. But yes, additional MRI would have been more useful. No doubt about it. To rule out, just to rule out anything. No fever, nothing.
Sir, biopsy is needed pre-operative.
No. Why? If it is inflammatory disease, infection, superadded infection, why it is going to help you? So case is ready and we'll go ahead with that.
Sir, the cribriform plate is fine or it has some cribriform plate in this case?
Yeah, cribriform is fine. That is, I mean, the bone erosion is there. Definitely bone erosion is there. See this?
Yes.
See this? It is
Yes.
fine, but because of the bone resorption.
Yes.
Bone
But there is
resorption and neosteogenesis, both things are going on.
But no history of CSF leak or something. No?
Nothing. This is not,
Nothing.
this is non-invasive disease.
Yeah.
It can give expensile bone erosions, can give neosteogenesis, bone resorptions. Bone resorption is due to